highlight why this matters for clinicians and how we see human and AI being the best possible model. There's just, as you know, as a clinician, it's not as simple as somebody just using a chatbot. Even in my own experience, even though I was inspired by increasing access to skill development, I was still forced to do leadership coaching. Like I wouldn't have done it otherwise. And so you really have to build that therapeutic alliance. You're going to have setbacks. You're going to have challenging moments. You need that human connection as part of that experience. And so we'll share, preview a little bit how we're embedding AI into that human AI experience. So as David kind of talked about, kind of those three components of the protocols, memory, reasoning, this is how we're starting to bring this to life. So we actually start with clinical guidelines. For example, a couple customers, the customer I mentioned using chronic pain. They have a whole clinical guideline that they use. They also use a behavioral activation. So show an example. It's like a 76-page guideline, very complex, text heavy. We take that and we run this through David's clinical reasoning engine. It then translates that into the specific coaching protocols and how to deliver those guidelines. It embeds memory. It also adapts the protocol so they're memory aware. So the protocols know, hey, if you have this piece of memory, here's how you use it. If you don't have it, don't hallucinate. So we're able to kind of encode that into the protocols. And then it creates essentially this separate set of instructions, which we call kind of the reasoning layer, which every turn of the conversation, it's saying, hey, coach, are you following these instructions? Yes or no? If not, all right, let's escalate or let's record this so we can improve the model. And then it's also evaluating the user progress. So how is the user responding? Actually, hey, coach, you really should transition to acceptance coaching. Let's move over to this train track. And I use that analogy because we talked a lot about an AI guardrails, and you can kind of put some instructions that kind of try to guide it in a specific way because we're encoding these protocols at every turn of the conversation. And you have this essentially this evaluator supervisor supervising every turn. You can't go off the tracks. You can't drift with this model, which makes it effective, but it's still very dynamic because the supervisor can guide the coach where it needs to go. And we're blending in this personalization by pulling from memory. And then the last piece I'll highlight is because we have these layers of protocols, memory, and reasoning, and we have the supervisor doing an evaluation every turn of the conversation, we can audit all of this. So as a clinician or as a platform, you can go in and say, hey, why did the coach do this in this situation? It'll actually record why it did that. And you can provide feedback to it. So, actually, I would prefer that it don't do that. It should kind of adapt it based on let's add this protocol for this situation. We run it through this agentic workflow again. It'll recreate the entire session, including the protocols, the memory aware protocols, and the reasoning protocols to adapt. So it's continuously improving based on human and kind of AI evaluation. So we can run actual transcripts through the system. It can self-identify where it could do better, and it will make recommendations on how to improve itself. So with that, we've got 2 minutes. I'll just quickly show some actual protocols and actual flow. There's a link if you go to our website, shiphealth.ai, go to the mental health providers page. There's a link to this full demo on the bottom of the page, and you can actually walk through how we took this behavioral activation clinical guideline, 76 pages. It's very text heavy, but very comprehensive. We translate this into these very specific coaching protocols, which you can see here. For every session, this is the first session, introduction, daily monitoring setup, coach instructions. Here's the reference checklist, everything the coach needs to do. And then it goes into each step, everything it needs to do. It'll have, again, memory aware protocols. So if you have this memory, here's how you use that. You can also see an example of the different types of memory we store. So in this case, every session we can access this and we can have the protocols reference specific things like daily reflections, the user goals, PHQ-4 screening, details on the functional impact assessment, personality types and patterns. And so we have access to this really hyper-personalized data that we don't have to go tune a model to try to access. We have it in a very structured manner, and we know what memory we should store in certain places and how to use that. And here's a quick example. And you can go to the website, kind of look through some more of these examples in terms of the actual protocols. And then here's a quick example of the supervisor. So for this first session, here's evidence verification requirements. So every turn it's saying, hey, did the coach do what it was supposed to do? And then it's also can dynamically transition the coach based on what's happening. And then this is just an example of for each different step, recording and creating an audible trail of, hey, show a quote showing understanding and showing monitoring. And why did the coach do what it did? And in this case, here's just one example that's now available to our customer. And then which is a comprehensive, it's actually 10 different sessions. It's like up to 3-month long program for behavioral activation. And then I know we're I think on time. The last thing I wanted to just share quickly, you can learn more on our website, but how we're bringing this to life for clinicians, I'll jump to this real quick. We're taking this to another step, which is you're coming out of a session in person or virtual, you have notes, you can scan your handwritten notes, you can take notes from your scribe, you paste them into our system. We can create custom programs for you. So I have a coworker who loves internal family system. We could build a custom program for him in a day. He can come out of a session and say, hey, look, I really want this person. Hey, AI coach, work on this resistance, work on a graded activity hierarchy. Here's what's working. Here's what's not. Here's where I want the AI coach to focus. Assign those instructions to specific sessions, including behavioral activation or even daily reflection. So you can embed IFS into the daily reflection. And now the AI coach is specifically following the clinician's care plan and exactly what the clinician wants to do, which then creates this extended care model. So you move from a 1 hour a week model to this continuous care loop where the human and the AI are continuously working together to optimize the care for the individual in the moments that matter, which is often in between sessions. So with that, we'll wrap up. I know I think we're 2 minutes over. So if you hang in there, and then I believe Angeline said there's a 15-minute gap. And so if folks want to stay on, David and I are happy to stay along and we'll love any feedback, questions you have. And if you don't have the time, please reach out. I'm Brian at shifthealth.ai. Any feedback, if you want to sign up for the early access waitlist, it's on the provider page. And I look forward to potentially working together. Thank you.
Thank you. This was really great. I loved hearing kind of your description of things. I feel like it's the right approach to do things. I guess I'm curious about kind of some of the safety protocols, and maybe you mentioned them, but I missed them. I imagine that at the supervisor layer, you have kind of in place if things go off the rails. I think there's a big dialogue about safety within our field right now. And I guess I'm just curious if you have a notion of kind of a supervisory layer and if things escalate beyond a certain kind of, I don't know, a system capacity of competence. Is there any human or therapist in the loop oversight? I guess that would be a concern that I might have relative to these systems. I think the way you're doing it sounds really appropriate and right, just in terms of it's kind of the different layers and the memory feedback loop. But yeah, that was my question about what you do in those kinds of instances. Thank you.
Yeah, great question. David, do you want to cover the core protocols, and I can address the human in the loop question?
Yeah, exactly. Yeah, that sounds great. Yeah, so there's actually yes, so actually the coach and I would think about it like the coach is really the AI instance that delivers the protocols. And so at the persona level of the coach, there are safety protocols pertaining to managing user overwhelm, any sort of indications of self-harm, harm of others or suicidal ideation with escalation protocols built in. And the same thing exists at the supervisory layer. So I would think of the supervisory layer in that context as a safety net if the coach doesn't appropriately address the question. This is kind of the second instance that makes sure that on every turn, and this runs on every turn, right? So every turn that the feedback is ignored, the supervisor will kind of repeat that feedback if the coach doesn't catch it itself. What we found is generally when pressure testing the system is that the coach actually is pretty good at appropriately catching these instances, and then based on the severity and based on what the user says, will either completely abort. It has instructions to abort the current session and not proceed with the session if there's any sort of crisis indication, and then refer to the appropriate resources. I know that in one of the earlier sessions is Someone mentioned they don't do the referrals. And I think that's something the human on the loop question is a little bit more what Brian can dive into. But yeah, we have implemented these safety protocols at multiple levels in the instructions. I hope that answers that part of the question.
Yeah, and just real quickly on human in the loop, as you can imagine with the way we built the system, that there's the supervisory layer, but there's also this kind of asynchronous layer, which is you can we have access to weekly standardized assessments. We have a weekly check-in session that you can do. You can integrate notes from the human sessions, and so in behind the scenes, our partners or mental health platforms can define the protocols to measure kind of the longitudinal progress of the individual, identify what are those high risk situations, and those protocols can be embedded at the patient level. And so as they're having these sessions, you identify, hey, you're going into an area where it's really better off if you're talking to me as a human. We can then guide the AI. And often cases, there are a lot of different edge cases around that I think our platform could really help support. But to David's point, anything that escalates to kind of an urgent matter, the coach generally handles like 99% of those cases, and then it's at like more 1% that it's more of a long tail of as a human you'd really want to human therapist you'd want to customize it, and we can do that, which is pretty powerful. But thank you.
And
Go
yeah,
ahead.
just to follow up, sorry, on that. So it's the 1% that I am a little bit worried about. And so could you specify a little bit more about how humans are looped in when that happens?
So that is defined by the clinicians that we're working with. And so, you'll have platforms that want to say, look, that 1% completely out of scope. I want the coach to shut down and not handle it. And you have some clinicians say, hey, it's in these cases, in these 1% cases, these should escalate to the crisis hotline. And then I want the insights for my next in-person session. I don't want to have the liability and be notified that somebody is suicidal because there are a lot of systems that clinicians use, and it's pretty standard, right? A clinician is like, look, if you're having suicidal ideation, don't call me on Saturday. Go to the crisis hotline, and those resources are very clear as you get onboarded. And so we really just structured around how the clinician wants to support their patient in between session. And so if there's certain use cases where hey, actually want to be notified, but the patient knows that it's, hey, this isn't an urgent matter, but it'd probably be very helpful if the therapist gives a nudge. We can auto generate those nudges and just kind of reinforce, hey, normalize some resistance if they're struggling with like actually doing the activities that maybe they came out of the session like, yeah, I'm going to do this. I'm really excited. And then really let down and feeling very down about their progress. We can provide that insight to the therapist if they have the capacity. I think that's something that is just going to evolve over time. Our goal with this is to really take the cognitive load off the therapist and reassess where they can make the most impact, both in session and in between session, and just make it really, really efficient for them to do so. There's a lot of this we haven't fully designed yet, but with our system, we can really customize it based on how the clinician wants to support their patient. Does that make sense?
Great, thank you.